topic of like a splanchnic nerve, which is considered as the autonomic nervous system. So we will have a two separate class on autonomic nervous system and these autonomic nerves of the thorax and the head and neck together. So we'll cover that content in the head and neck in second session or like the second half. But before that, we just like move to this particular heart and we understand this particular basic topics of this particular heart with these particular locations of it, which is present in the mediastinum, middle part of it, and we call them as middle mediastinum. It has a covering, we call them as pericardium. Now this pericardium have got layers. Outer one we call them as fibrous pericardium. Inner one we call them as the serous pericardium. Now this serous pericardium is double layer. So it has two layers. One is outside, one is inside. We call them as parietal and visceral layer. Between this parietal and visceral layer, this green blue line as you see here, this holds this potential space which is known as pericardial cavity or pericardial space. So if you see this is the outer one which is known as like fibrous pericardium, and if you see this inner side of it, which is like the parietal layer of this particular serous pericardium, and the visceral layer of this serous pericardium is blended over this epicardium of the heart. So inner side and outer side, which is in comparison of this particular pericardium, and once you open up this particular space, we basically land up into this particular pericardial cavity. So this fibrous pericardium, which is basically covering tough structure along with this particular heart, blending with this particular diaphragm below, blending with this particular great vessels which are present on the top side. And this particular fibrous pericardium is innervated by some nerves that we are going to learn about. This is about fibrous pericardium, we already have seen. We usually tag this particular pericardium and ask questions in pericardium related to it in the practical exams as well. So you got to know about this pericardium, pericardium cavity, pericardial sacs, and what about this particular pericardial cavity related to these clinical problems. Within this particular pericardial cavity, it holds two kind of spaces. These are potential space, just like the pleural recess in case of the lung or pleura we have. This particular spaces is present in this particular pericardial cavities. We call them as transversely placed space, we call them as transverse sinus. Now this transverse sinus is important because whenever you are going to do the open heart surgeries, we usually put a ligature following this particular great vessels. So this particular boundary of this particular transverse sinus we have to know. So anteriorly this particular arch of aorta and this particular pulmonary trunk present, and posteriorly it is that superior vena cava which is holding in the back side. Between them, if you pass on the finger, we get this particular transverse sinus. So boundary of this particular transverse sinus, which is a horizontal gap within this particular pericardial space, which is important for us because doing cardiac surgery, cardiac transplant surgery or cardiac bypass surgery, we explore this particular space for passage of the strings or ligature. So this space is important clinically and theoretically as well. So this question comes in about this particular boundary of this space and the clinical relevance of this term. Other than this, we have another space which is present in this particular back side of this particular sinus. Once you remove the heart, the leftover the pericardium is there, then we find this particular opening of these particular four veins over there, so which are pulmonary veins. So between these pulmonary veins, there is potential space which is lying in the back side. We call them as oblique sinus. So this particular oblique sinus is lying basically on the base of the heart or posterior to the base of the heart. If you split this particular region of this fibrous pericardium, you will land up into esophagus. So behind this particular oblique sinus, we have this esophagus lying posterior to it. So this position of this oblique sinus and the transverse sinus are important. The sinuses of the pericardium are short notes with the clinical relevance. So whenever you are learning this, running through this, prepare this particular thing well. So this is what we are talking about. This is the oblique sinus place. If you cut through, you land up in esophagus. Now transverse sinus and pericardial space and oblique sinus, these are kind of thing that you have to prepare. This is a schematic diagram, helps you to draw the whole things. Whenever you are given with any kind of short notes, you should be presenting with a short like relevant schematic pictures like this. So this particular picture you should practice for this particular short note about the sinuses. Now coming to this blood supply and the nerve supply around this particular region. So this pericardium is supplied with the branches of this artery which is known as the pericardiophrenic arteries and musculophrenic arteries, which is supplying, and branches of descending thoracic aorta supplying to it. And the inner layer is supplying through this coronary arteries like right coronary, left coronary, which supplies the muscle of the heart. They supplies this visceral layer only. Along with this particular arterial supply, nerve supply comes from the phrenic nerve. So, this particular phrenic nerve is a mixed kind of nerve capable of taking sensations. So, if this pericardium is having any kind of inflammations, this particular pain is picked up by this phrenic nerve, and this particular phrenic nerve has a root value which is coming from the neck region C3, C4, C5. So, these particular distributions of this particular C4, C3, C4, C5 is over the shoulder region. So, if you by any chance have any kind of pericarditis or pericardial problem, the patient may experience the pain over the tips of the shoulder. We call this phenomenon as referred pain sensation or referred pain phenomenon. We elaborate this thing in abdomen, because in abdomen we see so many cases where you see this particular referred pain sensation or referred pain phenomenon pretty much commonly. So, regard to this nerve supply and the blood supply about the pericardium that you should be knowing it. Now, coming to this clinical problems, the inflammations of the pericardium, we call them as pericarditis. If you have the inflammation, the touch pin temperature that phrenic nerve carries, and this particular patient feels the pain over the tips of the shoulder, and usually patient complains about the pain which is present in the pericardial or chest regions, and with this particular movement, just like if the patient exerts, if heart beats more frequently, then the patient experiences more pain. Other than this, if this particular pericardial space is occupied by the fluid, we call them as pericardial effusion. So, if you have this particular pericardial effusion, heart looks like this. We call them as bottle shaped heart, which is having a looking like a pitcher. So, this heart shadow, we can see that yesterday also we learned about this particular diagram decoding this particular heart shadow. You see that this particular heart becomes massively enlarged, and this is because of the fluid accumulation within this. Now, if this particular fluid is because of this particular blood which is accumulation happens to occur quickly, we call them as pericardial tamponade. So, if this fluid becomes blood and quickly accumulates, which we call them as pericardial tamponade. Now, for example, a patient has a stab injury in the chest region and hitting this particular arteries which is supplying this, and blood bleeds in and the blood gets into this particular pericardial space. So, it accumulates the blood rapidly. For example, in half an hour 3 liters of blood accumulates. Then what happens, this particular blood externally cramps this particular muscles of the heart. So, heart cannot beat, cannot relax, cannot shrink like this. So, that leads to the cardiac failure. So, that particular condition we call them as cardiac tamponade, which is a massive quick sudden accumulations of the fluid like blood within this pericardial cavity. So, you have to understand what do you mean by this cardiac tamponade. You do not have to explain these things because question do not come as a cardiac tamponade, but if you do not understand the clinical meaning of it, you cannot get through this particular problem where it is coming into it. Other than this, if the blood is coming over this particular pericardium, we call them as hemopericardium, etc., etc. Now, from the pericardium, we are getting into the heart. So, heart need to be learned very well because this particular content has got importance in the theory, practical, and as well as in the viscera part or viva part as well. So, parts of the heart that we have to understand over here, which is extending between this particular mediastinum, which is lying between the 3rd rib to the 5th rib, which is extending out of over here. It has got positions of the heart is present, like 2/3 of the heart is present on the left side of this midline and 1/3 is present on the right side of it. It has a pointed or downward, forward and dependent most part of the heart, we call them as apex of the heart, which is formed by the left ventricular chamber. The back side of the heart, we call them as base of the heart, and the positions of the apex is present in the 5th intercostal space on the left side, 9 cm from the mid-clavicular, 9 cm from the midline or just medial to the mid-clavicular line. So, these positions of this particular apex of the heart that you have to keep in mind. So, this particular apex, we have to feel this apex beat whenever you are examining a patient in physiology. In physiology practical, you have to look through this apex beat. You have to look for this particular apex beat and locate this particular apex beat in normal individuals. Now, coming to this particular heart with this particular locations, it has got some features. It has got 4 chambers, it has got 3 grooves. Out of that 3 grooves, we call this as an interventricular groove, which has an anterior part and posterior part, and atrioventricular groove, which is separating between atrium and ventricle. 4 chambers, 2 atrium, 2 ventricle. It has apex, base, 4 borders and 4 surfaces over there. So, it is appropriately colored in this particular picture. This is the right atrium, this is the right ventricle. The back side you are seeing the base, which is known as left atrium, and left ventricle. So, right atrium, left atrium, right ventricle, left ventricle, and separated by this right ventricle and left ventricle is interventricular groove or interventricular sulcus. Between this atrium and this particular ventricle, we call them as AV groove or atrioventricular groove. So, we have to correctly identify this. This is what we are going to see, that atrioventricular groove. The back side of the atrioventricular groove, this is the front side of the atrioventricular groove, also known as AV groove. Now, this back side of the AV groove is located by a venous channel. We call them as coronary sinus. Because of the lodgement of the coronary sinus, this particular back side or posterior part of this AV groove, we call them as coronary sulcus. So, these particular terms we need to know about. Coming from other one, this is we call them as interventricular groove. It has a posterior part, it has an anterior part. Anteriorly separating between the right and left ventricle, posteriorly it is separating between the right and left ventricle. Now, you see that this particular interventricular groove meeting with this AV groove at this point, where this particular two points meets over, or two lines or two grooves meets over here, this point or juncture we call them as crux of the heart. So, this crux of the heart you have to keep in mind or you have to know it. Other than this, the apex of the heart, which is the most downwards, forwards and to the left positions, which is formed by the left ventricle chamber. Base of the heart, which is present on the back side, form this left atrial chamber. You can see this opening of the 4 pulmonary veins, 1, 2, 3, 4 like this, they are opening into this. So, if you cut here, we will end up into this particular left atrial chamber. So, it has got this particular phenomenon or this particular features. Apart from that, it has got 4 borders: superior border, right border, inferior border and the left border. So, this particular heart have got border which is starting on superior border extending from this particular left side, second to third costal cartilage obliquely down. We have the superior border formed by the right and left atrium, which is present predominantly. From this point to this point, we have this third costal cartilage to the sixth costal cartilage with the curvature. If you draw it, you find another line, we call them as right border, which is basically representing the right atrium. From this particular sixth costal cartilage to this apex, if you join this line, you get this particular line, we call them as inferior border, which is formed by this right ventricle and complemented by left ventricle. And then we have this border from the apex to this particular superior border on the left side. If you are joining that, you are getting another border, we call them as left border. So, this particular 4 border over there, left border is formed by the left ventricle and little bit by this left auricle, which is contributing to it. So, you should be knowing about this particular borders, 4 of them, how they are present and how these particular chambers of the heart contributing to it. Coming from these particular borders, you have to know about surfaces of the heart. The surfaces are there, 4 of them: anterior surface, posterior surface, which is predominantly present. Anterior one, also known as sternocostal surface, predominantly formed by the right ventricle. Posterior surface, which is easier to one, which is formed by the base of the heart, also known as base of the heart, formed by the left atrial chamber. So, anterior and posterior, we decode this particular thing. Then we are left with this heart where it is sitting on the diaphragm. We call them as inferior surface, also known as diaphragmatic surface, which is formed by the left ventricle and little bit about the right ventricle. And then we are left with the left surface, we call them as left pulmonary surface, which is formed by the entirely left ventricle. So, all these surfaces that we have to keep in mind whenever you are observing the viscera, whenever you are presenting in the cadavers as well, you should be knowing about these particular surfaces. So, base, apex, surfaces, sternocostal and posterior surface, diaphragmatic surface and left lateral surface, all of them schematically you should be knowing, and as well as whenever you are seeing this organ itself, you should be knowing them. Coming to the interior of the heart, if you cut this particular heart, you get 3 layers. Inside out, we have this endocardium, myocardium and epicardium. Epicardium is covered by this particular visceral layer of pericardium. So, this particular 3 layers are there. Out of these 3 layers, myocardium is a muscle bulk which is forming this particular layer. Coming to the chambers, we have 4 chambers: right side, right atrium, right ventricle, left side, left atrium, left ventricle. Right atrium have got some features that you have to keep in mind or that you have to know. So, this right atrium, this is one which you are seeing here. It looks like a conical or kind of like a square shaped thing. So, it has a tube which is coming over here, which is superior vena cava, bottom line which is inferior vena cava. So, these two are joining together, putting all the bloods in our body into this small tiny chamber. So, all the body blood eventually gets into this right atrium chamber through this particular 2 big channels getting into this particular heart. So, this particular right atrium, if you see that externally between this particular right side, between this particular superior vena cava and inferior vena cava, if you find it, we find a groove existing here. That particular groove we call them as sulcus terminalis. At the upper end of the sulcus terminalis, where the superior vena cava opens inside, in the chamber, inside this chamber is a positions of a cardiac epigenic center, we call them as SA node. So, this SA node is present somewhere over here on this particular line, which is joining between this superior vena cava and inferior vena cava, we call them as sulcus terminalis, inside to it. So, inside to it where this particular superior vena cava opens, we find that point. So, this particular location of the SA node is again important, because clinically this particular SA node you have to access to put a pacemaker on it. So, these clinicians would like to know about location of SA node, and the clinical significance is that is to put a pacemaker if the heart is failing to beat properly. So, for that reason you have to know the SA node. Likewise, you have to know the AV node as well. So, we will coming into it. So, this particular external feature of this particular LTD of this particular like a right atrium have to know, and there is a conical like a circular kind of projections there in the top part. We call them as auricle. They looks like ear. So, we call them as right auricle. Looks like an ear, that anterior. You have seen that anterior border of the lung, which looks like an elephant ear. This particular element also looks like that particular element. Once you split open this right atrium, you get two chambers inside to it. One is rough chamber. This rough chamber, you can see the muscles in it. We call them as Crista Terminalis. So, these muscles which, these Musculi Pectinati which you are seeing here, and this roughness is because of the muscle, and it has a posterior part which is smooth. So, this interior of the right atrium has got two parts. Anteriorly it is rough, that rough part we call them as Musculi Pectinati or pectinate muscle. Posteriorly it is smooth, it is receiving the blood on the posterior side from the superior vena cava, inferior vena cava, and the opening through the coronary sinus. So, it is receiving all this particular posterior side with the blood which is coming from different directions. So, it has a smooth part and rough part. Smooth part is present on the back side, rough part is present on the front side. And between this smooth part and the rough part, we have a delineating line, we call them as Crista Terminalis. This Crista Terminalis corresponds with the sulcus terminalis. So, externally this groove we call them as sulcus terminalis, internally the same groove we call them as Crista Terminalis. Again, this is important because this Crista Terminalis inside gives us the clue to find these locations of the SA node. So, where this superior vena cava ends at the top point of this Crista Terminalis, here somewhere we find this SA node. So, here we put the lead of the catheter of that particular pacemaker at that particular point if you have to do the cardiac pacing or pacemaker implantations. Now, from this particular point we have to know about this particular septal wall that is present between the right atrium and left atrium. So, between the right and left atrium we have a partition. That partition we call them as interatrial septum. Now, interatrial septum have got features. There are two features that you have to keep in mind on this thing. One thing is that there is a depression there. This particular depression used to have an opening. If you had that opening when you are young or before you are born, this particular opening we call them as foramen ovale. Now, this particular foramen ovale is patched by some kind of patching thing. We have this muscle and the membrane covering it. Then that foramen ovale we call them as fossa, as a depression. Fossa ovalis is an oval shaped depression that is present in here. So, this particular depression which is present into this particular interatrial septum is a point of concern. So, if you do not have this particular patch thing present, we may have an opening, then we call them as patent foramen ovale, also known as atrioseptal defect. In short, we call them as ASD. So, this particular margins of this foramen fossa ovalis, we have this covering or bulge up region, we call them as limbus fossa ovalis. So, we have to know what do you mean by the fossa ovalis, we have to know about foramen ovale, we have to know about atrioseptal defect, and we have to know about the limbus fossa ovalis, which is the elevation margin part. So, this particular element is present inside to this cavity or lumen of the right atrium. Apart from that, we have this particular AV node positions. The AV node position we call them as it's located in the imaginary triangle, we call them as triangle of Koch. So, what is a triangle of Koch? This is a kind of imaginary triangle which is present in between these particular three landmarks. We have an opening of this particular venous channel of the heart, we call them as coronary sinus, which is present in here. This is one landmark. Then we have this particular interatrial septum, we have the cusp there. So, which is a valve which is present in here, and we have this particular thready part, we call them as tendon of Todaro, which is like a remnant of the valve to inferior vena cava. So, between these particular region, we find a triangular area between this particular septal cusp or this particular interatrial septum base bottom tendon of Todaro and the opening of this particular opening of this particular coronary sinus, we find an imaginary triangle. This triangle we call them as triangle of Koch. Why this particular triangle of Koch important to us? Because it is a location of AV node. So, we learn about this particular SA node and AV node, we will come into it once again, we land up into the cardiac pacing thing. So, this triangle of Koch will be again surfacing, the locations of the SA node will be again coming up whenever we are going to talk about this particular cardiac rhythm or cardiac epigenesis. Now, from this particular right atrium, we are moving to the right ventricle. Likewise, this particular right atrium, right ventricle also have two parts. It has a rough part, it has a smooth part. The general feature of the ventricle is that we find some muscles, we find some kind of bridging tissues, and we find a muscle, we call them as papillary muscle. So, whenever you are seeing this particular ventricle, inside to it we see three features: ridges, bridges, papillary muscles. So, these are the three features present in the right ventricle and the left ventricle, only it has a little bit difference to it. So, we are coming into it. So, this right ventricle, which is having two parts, as I am saying, this has a posterior part which is smooth, anterior part which is rough. Rough means it has muscles in it. The muscles of this ventricle, we call them as trabeculae carneae. We call them as ridges and bridges, which is present formed by the muscular ridges, which is known as trabeculae carneae. And on the posterior side, which is smooth part, which is receiving the blood, which is from the inflow part, and as well as throwing the blood from here to the pulmonary trunk. So, this particular ventricle have got two things, which is ridges, bridges, papillary muscles, which are finger-like projections. So, we have this particular bottom of this particular ventricles, we find a small tiny finger-like projections. So, this particular finger-like projections, we call them as papillary muscles. So, these papillary muscles varies from 2 to 3 in number. From the top of this papillary muscle, there is a string attached to the undersurface of this AV valve. So, that particular string we call them as Chordae Tendineae. This papillary muscle helps to hold this particular valves together when the ventricle is contracting, whenever the blood is coming out of this particular ventricle, from this particular ventricle to the pulmonary trunk or ventricle to this aorta, to hold this particular muscle contracts. So, this papillary muscle is helping to keep this valve intact. So, these papillary muscles that we have to understand and identify. So, this papillary muscle 3 in number in case of the right side ventricle. There are 3 of them, we call them as anterior papillary muscle, posterior papillary muscle and septal. Anterior and posterior is significantly large, septal one tiny one. So, these 3 of these particular papillary muscles which are present, and top of that we have a string attached, we call them as Chordae Tendineae. The string is attached to the undersurface of the cusp as well. So, this is how the papillary muscle present in the right ventricle. So, we have to identify this particular papillary muscles and Chordae Tendineae and the cusp as well whenever you are seeing this. Now, coming to its special interest on this particular ridges. So, muscles of this particular ventricle, we call them as septomarginal trabeculae, which is having a continuations of this particular conducting pathways which is present. So, one of the trabeculae carneae, which is a muscle in the right ventricle, holds a conducting pathway. So, we have this particular right bundle branch which is communicating from this SA node to this particular ventricle, which is transmitting this electronic impulses from the SA node to this particular ventricle muscles. We call them as this right bundle branch. That right bundle branch runs through this particular muscle fiber, and that particular muscle fiber we call them as septomarginal trabeculae, also known as moderator band, which transmits between this particular septal or anterior papillary muscle to this particular septum. So, this is about this particular septomarginal trabeculae and the significance of it. We will be learning this particular thing again when we are going to talk about this conducting pathways. Coming from this one, we are moving to the left atrium. So, left atrium likewise right side, I have got same thing, same feature. It has a smooth anterior, a smooth posterior part, rough anterior part which has a Musculi Pectinati, and the smooth posterior part which is receiving the opening of the fourth pulmonary veins, which is receiving all the blood coming from the lungs. So, it has got these two features, and this septum between this particular right atrium and right ventricle which is present as well, but this particular septum is more pronounced or more visible or more have features on the atrial right atrial side. Coming from this particular right atrium, we have this left ventricle. So, left ventricle which is the largest or thickest of all the ventricle chambers, it also have the same part, rough part, smooth part. So, this particular rough part, smooth part, it means bridges and papillary muscle. The number of the papillary muscle in the left side is 2. We call them as anterior and posterior. Otherwise, the papillary muscle have got same features. It has a base, it has a apex. From the apex, it runs through this particular Chordae Tendineae, which attaches to the undersurface of these valves. So, this particular valves which is present between this particular atrioventricular opening. Between this particular ventricle, likewise the atrium, we have a partition. We call them as interventricular partition. This interventricular partition has got two parts, membranous part which is present in the upper side and muscular part which is present on the bottom side. This particular interventricular septum projects into the right ventricular chamber. So, it is because of the muscle bulk of this left ventricle, this interventricular septum is pushed to this right ventricle chamber. So, it has a muscle part which is present in here, and it has a membranous tiny part which is on the upper side. The development of this particular interventricular septum, how they are formed, that we have to learn in embryology classes. Now, coming to the valves which is present here, there are two sets of valves that is present in case of the heart. Between this atrial chamber and ventricle chamber, we call them as AV valve or atrioventricular valve. Right side the valve, we call them as right AV valve. Left side we call them as left AV valve. Right side valve had got 3 cusps, we call them as tricuspid. Left side it has 2 cusps, that means 2 flaps are there. So, that is why we call them as bicuspid, also known as mitral. So, this particular valves which is present between this particular atrium and ventricle, we call them as AV valve. At the opening of these large vessels like aorta and this pulmonary trunk, we have 2 sets of valves there. We call them as pulmonary vein valve and aortic valve. This pulmonary valve and aortic valve, they have 3 cusps or 3 flaps are there. They are known as anterior, posterior and septal likewise, or anterior, posterior or medial, lateral, posterior likewise. Now, talking about these particular valves, these valves are anchored into some kind of fibrous network system of the heart. We call them skeleton of the heart. So, inside this particular heart, we have a skeleton system existing, and that particular skeleton is made of these collagen fibers and elastin fibers which is holding this particular thing. From this particular skeleton, the muscles of the heart or myocardium hangs there. So, do these particular the valves hang. So, this particular valve which is AV valve hangs to these particular skeletons of the heart, and it has got 3 components. It has like a base which is known as circular ring. It has cusp like 2 or 3 depending on the side, right side, left side, and this particular undersurface of this cusp, it has a string attached, we call them as Chordae Tendineae, and this Chordae Tendineae other attachment is to this papillary muscle. So, papillary muscle is anchored within this particular interior of the chambers of the ventricles. The papillary muscles have got 2 parts which is present. It has a root, it has a apex, and it has a body or which is extending between root and the body. So, this is how this particular whole valve system or component of this particular AV valve runs. Likewise, this AV valve, we have this particular semilunar valve which is 3 of them present in the aorta opening and pulmonary opening. They have the 3 cusps like this. This cusp looks like a half of a moon, like semilunar. So, that is why they are known as semilunar valves. Now, 3 cusps present on the right side, we call them as tricuspid. We name this anterior, posterior, septal. Likewise, we name this papillary muscle as well, anterior papillary muscle, posterior papillary muscle, septal papillary muscles. Mitral valve, 2 of them, bicuspid, anterior and posterior septal valves, and as well as anterior and posterior cusp are there, and likewise the papillary muscle is also known as anterior papillary muscles and posterior papillary muscles. So, these are the interior feature of this particular heart or ventricle chambers and atrial chambers. So, this is what we are seeing here together, all valves together fitted with this particular skeleton of the heart. So, whenever this particular heart muscles and the skeleton system gives an attachment to the valves. So, this whole network is attached to this particular point, we call them as skeleton system of this heart, which is holding this muscle and as well as this particular valves. So, this is all about this particular interior and the features of it. Now, coming to the conducting system, which we are mentioning beforehand in brief times. So, this heart has a rhythmicity, it beats at a particular rate. So, the rhythmicity of the heart is indigenous, that means heart can produce the beating on its own. There are some certain points in the heart that have the capacity to beat it. There are 2 points, we call them as nodal beating points, SA node and AV node. They are basically the beat setter or beat maker. So, SA node, which is the main beat maker, which beats this heart from the 70 to 180 or 200 depending on how much it is beating. But normal beating of this particular SA node is between 60 to 100. So, SA node location is there, is the terminal point of this Crista Terminalis, which is where this particular superior vena cava is opening here, that point only. So, it is ending on present on this particular region, we call them as pacemaker or the pacemaker of the heart. The second pacemaker, which is having or getting this rhythmicity, is known as AV node. The AV node is present in the triangle of Koch. Where is the triangle of Koch? Where we find the opening of the coronary sinus, the septal cusp and the tendon of Tudaro, which are present in this particular region before it opens into AV region. So, we have this AV node which is present. So, SA node to AV node, we have a conducting channel, we call them as atrioventricular or AV bundle. So, from once it reaches to this particular AV node, you see that this particular fiber or electrical fiber which lands up into this interventricular septum. So, this interventricular septum is allowing this particular channel to flow through here. Now, once it enters to this particular region of this interventricular chamber, it bifurcates or splits into 2 branches. One goes to the right side, other goes to the left side. We call them as right bundle branch and left bundle branch. So, within this particular interventricular septum, this bundle branch splits, or we call them as bundle of His. So, His bundle splits into right branch and left branch. Out of this particular right one, which is coming from this interventricular septum, it jumps from here to this particular base of anterior papillary muscle. This one we call them as septomarginal trabeculae, also known as moderator band. This was, we are referring that before. So, if you have any kind of like a problem related to this particular infarctions or lack of blood supply to this particular blood point or rhythms generating points, we have a lack of beat. Then we have to add some pacemakers to create an external force to create the rhythmicity of the heart. So, there is a kind of battery which we are implanting. Where we are going to implant the battery? We are going to implant the battery at this SA node point. We are going to implant the battery as the AV node point. So, again they can charge it up and can create that. So, for that reason, the pacing reason, we have to know the locations of the SA node, locations of the AV node. So, this is about this particular conducting system. In detail of it, you will going to learn about. So, bundle of His breaks down into small branches. We call them as Purkinje fiber. They go into the muscle fibers of the ventricle chambers and supply this particular ventricle. So, whenever this particular atria and the ventricles are there, they are kind of getting a rhythmicity. Now, coming to the important feature about this particular differentiating thing. Now, we have this particular groove which is present there between the atrium and ventricle. We call them as AV groove. Now, what is the importance of the AV groove? What it is related to it is that the AV groove is working as a partition between atria and ventricle. Now, why this partition is important? Because of this thing that when this atria is contracting, the ventricle is in a relaxed position. So, all the chambers are not contracting at the same point. So, that particular AV valve or AV groove which is present is giving a separation between atria and ventricle through the electronic transmission as well. So, when this impulse of this SA node, AV node is working on the atrial side, the ventricle is working in a relaxed manner. So, when the atrium is contracting, ventricle is receiving the blood. So, the AV groove or partition between atrium and ventricle is helping to halt this transmissions of these impulses from SA node to AV node to this particular bundle of his. So, it gets some time to blood to push out from the atrium, reach to the ventricle, and then ventricle starts contracting, atria relaxes. So, that particular rhythm can be achieved because of this particular partition between this particular atrium and ventricle. So, this is all about this particular brief about this heart along with this particular connection system, and this is what we are talking about, the clinical conducting system map up. We have to put a battery, we call them a spacing battery. That spacing battery needs a catheter. That's like positive and negative. In case of this battery we have to put a lead, right? So, we call them as leads of these things. So, these leads of these things which leads to the muscles of the ventricle, muscles of this particular SA node and AV node, that pacemaker can create this particular charge of this SA node and AV node, which was not beating properly, then it can start beating. So, we get a sufficient beat. Once the heart beats, it pumps out the heart blood which is coming out. So, this is what it is, an image of this particular SA node and significance of this particular AV node and this clinical correlation to it. So, with this we go to learn about this particular viscera, heart, and learn about this particular content. On theoretical basis we have covered, the practical which you have to learn this particular heart, interior of it, with seeing the viscera itself.